welcome to those that are joining us, and we're going to give it a minute or two to allow folks to continue coming in. Hi, welcome to those just coming in. We're going to give it another 30 seconds, I think, before we start, just to let people in. I'm having to multitask here, so it's never a great idea for me, but we'll try. Good. I think we'll start the webinar. So my name is Andrew Griffiths. I'm the Chief Exec of FedIP. BCS are one of the FedIP member bodies, and we organise between the whole of the member bodies of FedIP webinars on a monthly basis to talk about various aspects of digital and data and technology in the health service. So it's great today to have two experts in cybersecurity. I'm sure we're all aware of the growing importance of being cyber secure and the risks that there are involved if we let down our guard in any way, and just the risks that are generally out there. So I'm really looking forward to hearing today's presentation to explain some of that and how it relates to keeping our patients safe and benefiting the public in the way that we deal with our IT and digital services. So I'd like to welcome the two Michaels, Michael Knight and Mike Fell, and I'll introduce them shortly. And then what we will do is, if you've got any questions as we go along, feel free to put your questions in the chat. And then at the end, we'll probably have around about 15-20 minutes for questions. And I'll pick up from the chat then any questions that have been asked and put it to our folks today and see what they've got to say for themselves. And so we'll use the chat function really to manage the questions. Okay, so with that being said, I'll hand over to Mike Fell and ask him to introduce himself and present to us. And then once he's finished, he'll hand over to Michael, and then we'll move into the questions after that. Okay, so over to you, Mike.
Thank you very much, Andrew, and hello, everybody. So I'm Mike Fell. I am the Exec Director for National Cyber Operations here in NHS England. My background is 15 years in security, the last 10 of which have been in cyber security across a range of UK and overseas government departments largely, and for the last 2 years in the health sector. So today I wanted to share some insights about the realities of cyber in health. What is it that we are seeing in terms of the threats? How is it that we go about responding to those threats? And also some kind of fairly candid insight into the reality of the ground. And the reason that we're kind of doing this as a counterpoint between the two Michaels, as we'll call it, Michael squared, is Michael later on is going to give more of an insight about the local ability and the way that national solutions that are offered through the NHS interoperate with those local realities, which is not always a smooth handover from one to the other. So hopefully it'll be quite interesting in that regard with the different perspectives. But the reason that I start with this slide with some big numbers on there is this is a reflection of the NHS as seeing cyber as a patient safety issue. There are 875,000 GP appointments every single day. And if the technology underlying those appointments and supporting the GPs and the clinicians in the decisions that they need to make and the information that they need to have available, if that isn't available, the impact is on nearly 1 million people every day that in some cases might just have been frustrated if they've taken the time away from work for it, but in some cases they will be deferring the important healthcare that they need and diagnosis. And similarly, there is a financial cost. The cost to the NHS and the public purse is about £40 for every GP's visit. So even if we were to lose kind of a day's worth of GP's activity, that you're looking at kind of almost £50 million of additional expenditure that we're all going to have to pay for to make sure those people get what they need. So what are the threats that we see to those kind of significant scale of operations? We look back to 2017, kind of way more than 5 years ago now, and the WannaCry incident was the kind of poster boy of ransomware and cyber events in health. It really did kickstart significant investment and attention into what cyber looks like. And that was a wormable, destructive ransomware attack with a costed impact of £92 million of direct costs that were borne. A number of organisations choosing to disconnect from the internet with clinical impacts to protect themselves from it, and a situation across health where there really wasn't a unified response from that. We then move through to 2020 and we see the real kind of proxy for the acceleration of digital in health. Back in 2020, there were only about 1 million users of the NHS app. We now see about 33 million users of that app in any 1 year. And that raises brand protection issues as people know a trusted NHS app, and it acts as a proxy. We've also seen electronic patient records increase from 10% of hospitals having that to over 90% of having them now in a similar timescale. And it just shows the increasing reliance that we have on digital solutions. 38,000 kind of calls to ambulances a day. Again, that is all reliant on digital infrastructure. So that acceleration of it really does make it a patient safety issue when there are things that go wrong, as indeed they did in the Irish Health Safety Executive back in 2021, when the industrial scale Conti ransomware group undertook an attack against that organisation to the point where they had to bring the army in. They were offered the decryption keys for that ransomware event, but it still took weeks and months for them to recover with real patient impact. And then what we've seen in the NHS in the last couple of years is, as the investment of over £350 million into hardening the NHS against cyber attacks since WannaCry has taken effect, we've seen the supply chain become increasingly vulnerable. Most recently this summer with a destructive ransomware attack against a large pathology provider in London that resulted in over 1,500 elective surgeries being deferred, and over 10,000 outpatient appointments being deferred. And we've seen a whole range of other effects on the supply chain that have a knock-on effect on health. So we talk to ransomware as the reasonable worst case scenario here, but it's important to realize that there are a whole range of other cyber issues that affect the sector too. We see the supply chain. We have nearly 2 million staff in the NHS, and insiders, either unintentionally or by direction, cause a risk. There's £150 billion flowing through that makes an attractive target for anybody that's financially motivated. And also accidents can happen that result in IT outages as a result of that. Also, in the olden days, years ago, we talked about denial of service attacks. Unfortunately, due to the geopolitical tensions that we see in the world that we live in at the moment, in the last couple of years, we have seen geopolitically motivated denial of service attacks succeed against hospitals as well. So it's not a a single issue kind of thing that we face here, and we need to build defenses that are strong against all of these threats. And the way that we do that is through a strategy to build a cyber resilient sector by 2030. That may seem a long way off, and it certainly seemed a lot further away when we were writing that strategy, but it shows the reality of what a oil tanker we have to turn around to make cyber resilience, and also how strategically we don't live in a world where we think that we can stop every attack, hence why we talk about resilience rather than security, and recognize the need to have resilient clinical services that can work around in the absence of technology. So we're going to keep on with a range of national services that we already deliver at the moment, of which Michael ingests and uses a good number. And those include a 24/7 cybersecurity operations center using threat intelligence-led techniques to protect over 200 hospitals, undertaking assurance so that we have a granular, detailed understanding of the risk, and also using the strength of our scale to whip through the 30,000 vulnerabilities disclosed every year and select the most pressing of those and issue them as high severity alerts to help organizations with less cyber resources to focus on the greatest harm. And that's what we aim within the strategy. 5 pillars in this strategy, focusing on the greatest threats and harms. And that recognizes that we have finite resources, that we can't protect everything against everybody, and we need to focus where the threat is greatest and where the harm is. We also aim to defend as one, and this is a great phrase because it basically means anything to anybody that who chooses to use it, but ultimately it's about using that strength and the scale and diversity of the sector, of the 2 million staff, of the 2 million endpoints, of the sheer scale of it in our favor, and rather than looking at it as a problem, asking, well, how can we use information from any one of those 2 million endpoints to protect all of those at scale, and how can we use national teams to use intelligence-based approaches to then protect the whole system. We put people and culture at the heart of this, firstly because we recognize that that we need to increase the skill levels so that people are empowered to make the right decisions, but also to change the culture so that we are not in a victim blaming kind of world where people can raise risks with confidence that they will be treated sensitively and that people won't be punished. And that goes through everything from responsible vulnerability disclosure programs to a just culture where we can have professional lessons learned exercises and learn from it and support those who are raising risks in having those addressed. We also aim to turn the taps off. We, of course, have huge ranges of technical debt, of systems that were not designed with security in mind. We have to deal with those by focusing on the threats, but we also need to turn the tap off and build our future systems secure from the start. And then lastly, I've already mentioned this, we can't sit on our laurels and think that we can defend against all of this. We need to think about cyber resilience and threat tolerant, harm incident tolerant systems, and have exemplary response and recovery from playbooks, from exercising, and from preparing organizations for the long periods of outages that inevitably we see as a result of some of the cyber threats that we face. I'd like to turn now to a little bit of reality about when things do go wrong, because it's very easy to sit in a role like mine and encourage others to be transparent without necessarily doing that ourselves. So it's important for me that we do share the scale of what we see. There are thousands of cybersecurity incidents dealt with within the Security Operations Center every single year. And when we have to deploy cyber incident response teams, there is a cost to that. The impact is not only in the hours that are spent on those response teams and the financial cost that comes directly, but also on the impact that, you know, Michael has kind of close personal experience of recently, as a number of people have. You know, staff working around the clock, staff working on incidents when they would be better spending their time working on securing the systems that they know. We have personal impact of clinicians who are increasingly used to working remotely, having to have remote access solutions taken down in incidents, meaning that patients can't get the swift results that they need and expect. In some cases, we've had to revert to pen and paper, which creates inhuman scales of paper that either then has to be discarded securely or hopefully manually input or scanned back into systems once they're live. And we know of some tragic cases where cancer treatments have been delayed due to incidents, where people have had to make hard choices clinically about what tests are made available for people, or about indeed the type of treatment that can be available to people where the full suite of services are not available. And the reality of the thousands of incidents that my team look at every year, and the tens of cases where we have near misses or actual ransomware or catastrophic kind of destructive cyber attacks, the reality of those is that whilst we think to 0-day funky, choose your name of the cozy bear, fancy panda kind of level of attacks that might hear, the reality is this is not 0-day attacks taking place on really niche medical devices that are kind of the work of science fiction. The nuts and bolts of what's going wrong is foundational failures in things that we have said time and again should be in place. We see remote access solutions being exploited. We see phishing being successful in gaining usernames and passwords. We see critical IT vulnerabilities that we have already made public through the high severity alert process not being resolved or patched. We see the absence of the national services like the 24/7 monitoring being in place time and again in organizations that are suffering these. And we see the absence of multi-factor authentication. These are in many cases hard to deploy, but they are not some secret source that nobody knows about that is going to raise the bar. It is really the foundations of the security programs that we want to see, not only in health, but across all sectors, to raise the bar and make the criminals or others move on to other targets. So the ways that we talk about preventing the attacks, it's the things that I've talked about there. At the start, getting connected, events like this, all the way through, we run a cyber associates network for over 2,000 people that work in cyber in the health to share information about real live attacks, about intelligence, and about the advice that we are sharing. Reviewing weak passwords, we've seen incidents with passwords as weak as dental for the username and password, so reviewing and getting rid of those. Even getting rid of passwords where possible and using the best of multi-factor authentication to make passwordless access a reality. Configuration and segmenting, reducing the blast radius such that when an attacker gets in, they're not able to access everything, and segmenting the networks to limit that blast radius, through to preparing for the worst, testing, exercising, having the board level conversations, the clinical conversations about what would you do if that worst day of your career kind of comes upon you and you get the phone call or the email or the tipper saying that there is an incident on your system. So I'm going to wrap up at that stage and hand over towards to Michael, and we'll pick up questions that are in the chat towards the end of things. But hopefully that's given you a sense of the scale of things in cyber in health, the existing national services that we deploy in an attempt to provide an umbrella to protect people, and the kind of advice about the learnings from incidents that we've seen on the ground. Over to you, Michael, to share with the group exactly what it does feel like away from my distant national role, what it feels like on the ground.
Wonderful, thank you, Mike. And hello, everybody. My name is Michael Knight. I'm the Chief Information Security Officer at NHS South East London Integrated Care System. So I've been part of the Integrated Care System for about 3 months now, and it's been incredibly busy. Really proud to be a fellow of the BCS and to be invited along today. And my background in health and care goes back kind of 15 years. So I've had the benefit of being part of national organisations like Mike, but also working through CSUs, working with community providers and in acute hospitals as well. So hopefully some interesting kind of reflections and insights from working in different kinds of organisations, and certainly something that I'm finding useful in the day job in the past few months. And I think one of the things that we kind of talk about within integrated care systems is we talk about the wider determinants of health. And I thought it was an interesting concept to actually talk about the wider determinants of our information security at integrated care system level. So, cybersecurity doesn't sit in its own special little bubble that is completely outside of the circumstances that our broader organisations have to deal with, right? We have to operate in those same circumstances. So out of the 42 integrated care systems in England, the plan this year is to deliver a budget that's a deficit. So not balancing the books is a reality for 31 of those organisations. I'm sure if you've read the newspapers or watched the news, and there's been plenty of coverage of the kind of the crumbling estates and architecture of the NHS, and a figure that I found to be 11.6 billion of backlogs in maintenance. So it may well be that actually when we speak to our colleagues that are directors of estates, they may feel like they've got a raw deal compared to us in terms of the kind of funding that we've got access to. But in my view, there's certainly a parallel between the crumbling physical architecture and also the kind of the digital kind of technological architecture as well. Likewise, there's a lot of cultural challenge at the moment within health and care. So there's industrial action. People are feeling in not the best place to be somebody that works as part of health and care. Again, we operate in exactly that same that same kind of system in terms of our technologists, our cybersecurity folks, and certainly where we have then the knock-on impact of strikes, etc., both in terms of the patient delivery aspects, but also all the work that then has to happen in the background to mitigate those risks as that's happening. And my last check kind of showed well over 100,000 vacancies. We talk a lot about not having enough nurses and doctors and allied health professionals, but we also have exactly those same challenges in terms of our technology teams and certainly in terms of our cybersecurity profession, an area that is incredibly competitive and where there's a really big market beyond the public sector for those really vital skills. So I think the key thing for me is that having a strategy that's really ambitious is super helpful, and having kind of that clear direction helps us to have the right conversations. But there are certainly some quite challenging realities in integrated care systems up and down the country. And some of the things that I kind of just wanted to share, some of the things that I've kind of come across in my first few months as a CISO in an ICS, which there aren't too many of us. Wish there were more, as well as some of the challenges kind of reflected in previous roles where I've kind of held cyber as part of my portfolio. So I think there's really an aspect at system level when we talk about, well, how do we align our cybersecurity activities and the controls we put in place with our risk appetite? And when we do that as an integrated care system, who gets to choose? Whose appetite is it? You will have NHS organisations that work across multiple integrated care systems. You have organisations that provide private services as well as NHS services. So actually, that's quite a challenging conversation, and certainly that's been a surprise for me. But there's also the piece around the perception around, actually cyber is quite a complex thing, and do we really understand it, and how do we understand it at senior level in the organisation? And I'll happily come on in a moment to share some thoughts on that. Systems have had the benefit of central funding for the past few years. That's been supported by Mike and the broader team, as well as folks in Department of Health and Social Care. And now the focus on the greatest risk and harms has been to focus on organisations with the highest impact. And there's certainly that's cause some constraints in terms of perhaps some of the areas where we've got higher likelihood we might want to get on top of. So that's certainly one that's a challenge that we're working through. As I touched on earlier, aging technology platforms we have in health and care, we have a lot of technology debt, we have a lot to get on top of, and that is a real challenge for organisations. There's also the reality of incident response. So within the NHS England, we have a reasonably hierarchical structure. We have national bodies, we have Department of Health and Social Care, we have NHS England, and we have both central and regional teams within NHS England. We also have an integrated care board and then a provider organisation. And then you may also have a supplier as well. So potentially, 6 organisations that are all potentially trying to be in the room and are interested. But you then have also multiple teams. So you have emergency planning focused colleagues. You have colleagues involved in the more operationally focused and clinically focused response, as well as folks involved in the cyber response. So if you have 6 organisations with 3 teams, there's a lot of stakeholders to manage whilst you're going through that incident response. So yeah, that's a really interesting kind of dynamic, particularly when you have an incident that's quite high profile. And as Mike touched on earlier, the supply chain of health and care is enormous. 80,000 different organisations. Each one of those organisations, what you'd want to do is you'd want to be looking at them now when you're making your decision to buy, but also for the duration of the contract, and you'd want a really broad coverage of that ongoing assurance. But clearly, that's a real challenge when we're operating within the constraints that I've kind of touched on a little earlier. That's kind of the doom and gloom piece, and it's important to kind of share what do I think we should be doing within integrated care systems. So on the risk appetite point, I think certainly I've been really impressed with when I've spoken to the integrated care system board about looking at that risk appetite in a more cohesive way. And so that we can properly focus on kind of the greatest risk and harms to us as an integrated care system. And on the complexity point, certainly for myself, when I've been speaking to the board, I've been really trying to talk about the very basic principles of risk management. So talk about how do we mitigate the impact, so through rehearsal and preparation and planning, and also the likelihood in terms of those technical aspects of it and the controls that we then apply to both of those things. So they don't need to know all of the details. They don't need to know that you need to go and buy a left-handed treacle bender to protect you from the latest threat. What they need to know is what's the likelihood, what's the controls, and how does this fit into our broader system. So I've very much kind of pitched it in that way, and I found my board to be incredibly receptive to that. In terms of the kind of funding allocation and the constraints, certainly as a system, we've been working really hard on how do we explore some more collaborative approaches to make sure that we can maximise and share the benefits more so than we've perhaps been able to do in the past. And I've been really pleased with the support from system partners on that. In terms of the aging technology platforms, now that's a real heavy capital funding intensive piece of work. So we're going to be looking at where do we have opportunities to gain resilience by doing things together, and that's a kind of really key part of what we're doing to operate within those constraints. On the incident response side, I kind of touched on earlier the kind of the complexities. So certainly there's more work kind of needed to rehearse those things and pick up on those points of integration, and that's certainly something that as we go through our lessons learned activities in the coming months from some recent events, we'll be having a look at those in particular and seeing where the gaps are and what the challenges were and what we can do, but also how our kind of colleagues up and down the country can benefit from our experience. I think on supply chain, interestingly, since I wrote this pack, I spent a day with Mike and colleagues from NHS England, and they've been sharing more with plans around supply chain assurance, but really important that we have real clarity over what's going to be assured centrally, because we have some really big players that are really important nationally to the NHS, so that then at a local level we can then say, okay, great, we know those X number of suppliers are being dealt with. These are the ones that we now need to go and target next because they're next on the level of risk to us as a system. So that's a bit about how it'll come over to, but I would like to give credit to colleagues in NHS England. So the presence of a national strategy that sets out really clear expectations is incredibly helpful. It gives me a real point of grip to work from with colleagues within the system. And actually having the imperative, the expectation that we will provide a system cybersecurity strategy as part of the annual planning cycle this year is super helpful. Mike also touched on the tooling and the services that are available nationally. That is invaluable. I look at those tools and the data that comes out of them frequently. That really gives us the best chance of getting on top of what the most important areas of improvement are for us. And that is something that I know Vin Duraker said is kind of opening speech for an event this week. That it's the envy of health and care systems in other countries across the world. So lots of really great stuff we have access to, and certainly part of my job is how do we get as much benefit out of that as possible. Of course, having some access to central funding is also super helpful. From my perspective, this is about using it to accelerate where we're trying to get to, not about funding our full kind of cybersecurity improvement program. It really is a kind of a drop in the ocean in terms of what systems should be investing to make sure that we manage this risk. There is also the new DSPT CAF, which certainly category 1 responders will, so your ICPs and your trusts and some of the arm's length bodies will be kind of moving on to in the next few months. For many years, Mike's predecessors will have been quite unhappy, and sometimes are visibly unhappy, when I challenge them on, can you just provide us with real clarity over what good looks like and what the framework is? And there wasn't that clarity. So I'm really pleased that we've had the benefit of Mike and his counterpart in the DHSC and the National CISO, Phil Huggins, who have given us that real clarity. And I think that's been done by getting out, speaking to people and listening to those challenges and then moving on to do something about them. So big thank you for that. I think finally Mike touched on earlier the work that's being done to develop the profession. So the Cyber Associates Network, we also have the Cyber School starting up again, hopefully in the coming months, where we'll be able to give some real specialist training to folks within our organisation. So lots of really helpful stuff happening on a national level that has a real impact for us at system level. So that was it for me. Hopefully that's been kind of just a useful rundown of how we're translating some of the things that are available nationally and how they have an impact for us at local level.
Good. Thank you both very much. That's been really interesting run through the landscape of cybersecurity, and we've got a couple of questions already. I've got a few myself, but I'll hold myself back for the moment. The first one that you will have seen there is from Mike, and it's making a statement really, but that one of the scenarios that is quite challenging is if clinical data is changed as a result of someone coming in, I'm assuming sort of subversively and not letting you know they've come in, and then wholesale or even individually changing records for an individual person or whatever, which would have a detriment to their health. Have you got any thoughts on that, either of you?
Yeah, I'm happy to pick up on that one. I think it's a very fair observation, Mike. So, and I don't say that just to make friends with and make it kind of Mike cubed on the call today. So strategically, we talk about focusing on the greatest threats and harms, and whilst ransomware itself, arguably, yes, is not the worst situation we could be. When I talk to a reasonable worst case scenario, it's that classic multiplication of likelihood times impact to get to risk. And the truth is, the likelihood of a ransomware attack on a hospital in England is the highest of all the cyber issues that we see, just evidently from the incidents that we're dealing with. and then you combine it with the impact, and clearly, yes, we've got an effective national control in place and local controls that have been successful on the whole in preventing ransomware. It's that kind of risk assumption that means that we focus our efforts on that bit. However, ransomware is but one part of the threat vector, and different techniques are applied. And obviously within our playbook, one of the questions that we ask, a ransomware operator needs to get access to the network, and you then have an unauthorized user on your network that could do anything. So yes, of course, with any cyber incident, the question about confidentiality, integrity, and availability are all key ones. In a clinical environment, changing the data, yeah, it could have massive consequences. And I think the kind of headlines have been in there in the past about the ways in which that can be done. But the reason that we frame it in that way is the focusing on the greatest threats and harms. And unfortunately, the UK is in the middle of an epidemic of criminally motivated ransomware attacks. And it is that which we need to do it, but also whilst keeping an eye too, as I'm sure Michael will validate, all of the other cyber risks and threats that we face.
We've Mike has got a little bit of a comeback on that. It depends on whether the traditional likelihood times impact is a good way of assessing risk. Any comment on that?
I mean, it's imperfect, isn't it? I'm not going to sit here and say let's go and play snakes and ladders on a 5x5 matrix. It's not, and that's why we do wrap it in with a threat model, and actually a more mature, whether it's bow tie analysis, but threat modeling type approach to this, about actually who are the threat actors that we are aiming to protect against, and choose your framework, but what are the different ways in which they could choose to intentionally or unintentionally cause harm. So yeah, absolutely, Mike. This is not a simple activity, and I kind of caricature it about ransomware being that, and it is because of the evidence that we see. But as we saw with the pandemic, you can't ignore the black swans, because black swans do exist.
Yeah. No, good. Thank you, Michael. Have you got anything to add to that on that question? Or?
No, Mike said what I was going to add.
Okay, good. So the next question we've got then from Prasindu, if I got your name right, is how does the NHS integrate technologies such as AI and machine learning into cybersecurity strategy, particularly for threat detection and response?
I'll happily share a little bit of my thoughts on this one, because it's certainly something that we've discussed as part of our cybersecurity strategy. I think certainly from my perspective, these technologies are changing so rapidly that in a kind of multi-year strategy, it's actually very difficult to set out today how we're going to protect from things that will rapidly change in the next few years. So things like, if we talked about quantum computing, for example, how are we going to secure that today? Frankly, we need to get a little bit closer to what that looks like to fully understand it. Now, clearly, kind of the AI aspects and machine learning are already here and already upon us. So really, I think it's about having a very clear approach of making sure we are A, identifying, and B, then doing that more detailed analysis on what does it mean for us. But also how close can we let those technologies get to kind of what I call the crown jewels. And then just taking that risk-based analysis of now, what does that mean in terms of how we protect them? What does that mean in terms of what we might want to do with hosting that kind of service? Do we want to do? Is it reasonable for us to build? Do we want to buy it? If we buy it, what are our requirements? And all of those things. I guess with the AI, you've also got the kind of attack versus defense benefits of that as well. I think certainly there's an aspect there of lots of organizations. When I talk to them about their products and services, they always want to tell me about the AI that they have. And I think there's, coming back to kind of Mike's points earlier, now what we are seeing happening today in reality is quite quite fundamental foundational controls that have to be put in place. So I think there's a bit around maintaining pragmatism, but being kind of prepared and having a plan for that, because certainly when our current encryption methodologies don't work anymore, we're going to have to pivot pretty quickly. So yeah, that's my view on it, which is a slightly meandering one, but hopefully that's given a bit of insight for you, Pasindu.
Mike, anything to add?
Yeah, I'll just add, kind of working backwards. I think there's a link between Mike's challenge in the previous question and this, and actually, how much do we focus on the now versus the future, and post quantum cryptography. Depending on who you believe, we're anywhere from 6 months to 10 years away from it. But it's one of those great examples about this is a juggling act. You can't simply focus on the future or the current. And we are investing time already to think up through that post-quantum cryptography challenge and how that would be addressed. I think working back from it, I mean, AI, yes, this year has really seen the acceleration of that because of the immediacy and of generative AI. But we can't forget that machine learning and other AI NLP techniques and that have been used by cyber professionals in the defense for years and years to work through the inhuman scale of data that's necessary to keep these challenged. So we're in a really good place to actually continue to do that. And as somebody that struggles to fill roles frequently, amazing opportunities of taking the real mundane aspects out of what it's like to be a cyber analyst on the ground, and stop cutting and pasting IP addresses from one system to another and spending hours and days training people to use really kind of unique query languages when we can just use a natural language approach enabled by AI. But that requires the foundations of security, which is effective risk management. And AI, just like the metaverse last year and blockchain the year before, is just another technology with its own risks. And I think we need to bring it back to the foundations of what we're good at, which is risk management and just understanding and managing the risks so that we can get the business benefits and the clinical benefits of AI, like most technologies that we're faced with.
Yes, no, that's well said. A good snapshot about AI generally, I think. Good. Next one is from Claire, and she's just asking, can she know a little bit more about cyber school? Can one of you point her to where she can find out more, and just give us a little snapshot of what it's about?
I think I mentioned it, but it's an NHS England scheme, so I'm happy to share what I know, unless Mike's particularly keen.
Go for it, Michael.
Cool. Okie doke. So I think there's a piece of work that's being done through the NHS England regional leads, and they are liaising through the relevant lead within each one of the 42 integrated care systems in England. So this is effectively funding for a particular set of courses that will be available to folks working within the cyber profession. So there should be some kind of cascade through from integrated care board through to kind of provider organizations to share the awareness of that. And of course, the funding is probably unlikely to cover all, however many. I think we've got 2,000 people in the kind of profession kind of signed up to to the group kind of with NHS England that run. So clearly not going to cover everybody, but yeah, certainly some good stuff helping there. It's the kind of thing that I've personally benefited from in the past, where I've been able to get some development support on that, and that helped me along on my journey. Ironically, I did my course about 3 days before WannaCry happened, and felt significantly more prepared for it.
Good. Mike, did you want to add anything to that? Or?
No, just to say that people and culture is one of the 5 pillars of the cyber strategy, and a key part of that is upskilling and making more consistent. I think it's no surprise that the NHS struggles with consistency of the grades at which some people are appointed across the system, and also can't necessarily offer the training that's required to keep pace with the technology and the threat. And that's something that we aim to address through the cyber program, the cyber school being one aspect of that, alongside other kind of interventions to help address that. It's a UK and global wide issue, but the NHS can be a great incubator as well, in that if more cyber professionals are built, shaped and developed in the NHS, even should they go to work elsewhere, it's a net contributor to UK PLC. So I think we've got a huge opportunity with the 2 million staff that we have to build those who want to do it internally, as well as help the wider community.
Yeah. No, and if I can just take my sort of chair's prerogative and just dip in as well, I think that's one of the benefits of joining BCS, getting professionally registered through FedIP, is that it does sort of highlight and provides that pressure, really, that we want to be, the digital data and technology folks are treated as a profession, where there is a requirement to keep up to date with our training, and make sure that we are treated as other professions within the NHS and care. So please do get involved through a professional body, get professionally registered, provide that impetus really to make sure that we're taken seriously and get the training we require. So lots of opportunities, I think, for training. Totally agree with that point about we need to be growing more, because it's not a loss to us. If they go off somewhere else, they may come back, and it's good for the UK. So that's a good message. Here's another finance one then. Given the planned, Vitaly says, given the planned ICS deficits, how does the resilience strategy balance that cost efficiency with the need for robust security?
That's a $1 million question, right? So that's a really significant challenge, right? So and that's the kind of the reality of it. So I think there's absolutely the points for us to consider, and it does come back, and I hesitate to mention it, but it's making sure that we have proper understanding of what are your crown jewels, what's got the biggest impact, and what controls do we need to put around those things that are likely to have the highest impact. So it's really about making sure that we get that right balance of focusing on the right things with the right mitigations around them. So not trying to have things that are lower impact, or to you having platinum standard services around them. It's really about that kind of foundational basic kind of risk management approach. So that's a really key part of it, and it takes really grown up conversations about organizational risk appetite. And I know that I know people outside of the NHS that I've spoken to at these similar roles, they will speak to their board and they'll say we don't want any cyber risk, and they kind of say, well, okay, it's probably my time to pack up and go, because that's not a thing. And unless we still have people, fundamentally. So you can't entirely eliminate the risk. But what you can do is you can focus on the areas that are of the most impact to you, and of the highest kind of likelihood to you as well, and really focus on working those down and making sure there's a really clear way of quantifying the risk that remains after that, and then you can have that sensible conversation around, right, okay, well here's where we're at, this is where you want to be from a risk appetite perspective, this is what we need to get there if we're not currently there. But it's certainly a challenge. One supplier in the past has given me the example of, if you didn't have a front door on your house, even if you didn't have the cash, you would probably try and find it to secure it. And that's quite a useful analogy that I may or may not choose to use at some point in the future. So yeah, but it break it down again to the foundationals and fundamentals, and focus on the greatest kind of risks and harms first.
Oh, great, thank you. Mike, have you got a magic pot of money in the centre ready to go out?
If only, no. If only. I mean, I think like Michael kind of set out in his presentation here, there's competing pressures, and CEOs and boards are not are not deprioritizing cyber because they don't care about it. They're making really hard calls between repairing buildings that are using reinforced autoclaved aerated concrete and are crumbling, and historically the costs of industrial action, and then elective backlogs as a result of the pandemic. And cyber's just in that. And I think, unfortunately, as security professionals, we've arguably not been very effective at quantifying and articulating this in that competitive environment. So at a national level, one thing we're doing is a lot of work through the programme to provide consistent visibility to boards, such that there is a consistent way of showing the risk and making visible, the patching levels of legacy technology and those bits consistently, and then quantifying it, and actually putting a cashable value, such that when the cost of repairing something and the cost of closing a ward because it's a state situation isn't safe, they can have a meaningful conversation about, cost benefit of that versus potential cost and benefit of the cyber.
That's great, thank you. I'm going to jump down to an interesting one. I'm sure everybody would be interested in this, from Sindhu. Can you share some lessons learned from the recent cybersecurity incidents?
Yeah, so I mean, this is a topic I'm always happy to talk about, because there's no point us sitting on a load of intelligence if it's not actionable. So it's kind of doubling down on what I said within my presentation here. The foundational failings that we see time and again are those which are letting people down. Of the kind of times that we have had to deploy cyber incident response teams across the NHS in the last 2 years, none of those have been using well-configured national services holistically. And in every case, for those in NHS, in hospitals, the application of multi-factor authentication would likely have prevented, if not significantly deterred, the activity from taking place for that. So, what are the lessons? The lessons are focused on the foundations, look at the critical vulnerabilities, apply multi-factor authentication to public-facing services, do incident exercising such that you know how you would respond in the event of an incident, and where national services are available, use them. They're free of charge. They're already being paid for by the public. Those are the things that we have seen. And that isn't to say that it's going to protect everybody against everything all of the time, but it is absolutely the root cause of the kind of incidents that, of course, come closest to causing harm.
Anything to add to that, Michael?
I think Mike's got it spot on there. It's really about doing those foundationals basics well, and using the things that are available to you kind of free of charge. I think the other one for me is being really clear on scope management. So and certainly whether that's internally yourself or in your supply chain, so where there's a national kind of mandate around multi-factor authentication, be really clear and have a really good think and look at your whole architecture and make sure you've got it in all of the right places that you need it, rather than just saying, okay, well, we've done it for this one thing, and leaving a number of gaps kind of elsewhere. So that's the proper scope management of those controls is really important.
Good, thank you. I was around in 2017, it was it, when WannaCry happened, and I think it was, as you've already observed, one of the greatest emphasis of the potential risk, even though it was actually quite a mild situation. Certainly I was in the NHS in Wales at the time, and I think it would be fair to say we probably overreacted in defence. Not that I'm saying that was the wrong response, I think it was a good response. But one of the things that, when all said and done, one of the things that where we actually were seeing the WannaCry, whatever you call it, fires coming in and being spread from, when we tracked it down, it was actually the vulnerable device was a till in a canteen in a hospital that hadn't been patched, and nobody realised this little till was connected to some supplier somewhere that was using their link to update the price list for the till. and that introduced the vulnerability, and that was the one that was sending out the WannaCry stuff, as it were. So, which brings me nicely out to Mike's other question, which is how much is the Internet of Things and these connected other devices a threat to our security? Anybody?
I think it's massive in terms of the kind of that threat surface piece, certainly. So a real opportunity for significant growth of the number of assets that you kind of have to make sure you have kind of visibility of, and I think it comes back to the kind of the basics of asset management and where they need to be network connected, your network segmentation, and those kind of things. These lots of these devices, particularly in health and care organisations, are incredibly valuable in terms of patient care, and being able to kind of manage that kind of risk in particular is a real challenge and a real concern. So something that within our integrated care system we have been discussing, because it's a really kind of big and growing challenge for NHS organisations up and down the country.
Yeah, another front to fight on, as it were.
Indeed.
Trying to draw this to a close a bit rapidly, Alex is asking the question, what might the impact of the US health insurance companies paying of ransoms following the Change Healthcare hack have for us in the UK? I'm not personally aware of that particular hack either. Mike or Michael aware of it?
Yeah, I'm happy to pick this one up. So I think in terms of a just culture, I generally kind of don't like to comment on individual cases, but I think it's a matter of public record that the United Health Group Change Healthcare organisation was subject to a ransomware attack, and with public reporting on that they paid a 22 million ransom, and then reportedly as well, the attacker came back and asked for more due to some internal politics of the ransomware group, I believe, with it. I mean, I think the UK policy position on this is incredibly helpful and incredibly powerful. The UK government does not pay ransoms, and we are signatory to international treaties that emphasize that and encourage others not to. The relative kind of security of the NHS itself, I genuinely believe, is higher as a result of that known fact that we will not pay ransoms. And it is something that, again, we've been on record with recent incidents. Ultimately, these are criminal groups. You can't trust a word of it, and the evidence is stark, from the Colonial Pipeline attack to the Irish HSE one to a range of other ones, where paying the money doesn't necessarily guarantee you to get the data back. It in many cases encourages a double tap, a repeat attack, and it certainly, and the ICO have made a joint statement with the National Cybersecurity Centre, it doesn't absolve you of any of the legal accountabilities under GDPR. And it in no way mitigates the action that's been taken place, and the data is still there. So all of that probably gives you a sense of what my view about paying ransoms is. I don't actually think the fact that that healthcare elsewhere chooses to do it increases the risk to the NHS. But I think in terms of the supply chain, there's questions to be asked about why the UK healthcare supply chain has been kind of targeted in the way it has, and whether there is a correlation or a causation with those that have chosen to use that as the route out of an incident.
No, that's a really interesting point, isn't it? I think there's lots we could talk about around that. I'm recognizing the time is quickly going. I said we'd end at 2. So I just really like to thank you both ever so much. It's been a fascinating talk. There are more questions coming, so this is clearly an area we can definitely return to quite quickly. There's lots of aspects I was going to explore as well, like the impact on people, which I think is massive, isn't it? If you're in an attack and responsible for that situation, that's massive pressure, isn't it? And we need to think about how we cope and allow people to survive in these situations. But some really helpful stuff there today. So thank you both ever so much. Just leaves me to say as well that in the series that we've got of these webinars, The next one is being hosted by IURIM, and just to show you the variety of topics that we cover, I'm sure that there may not be a huge crossover between today's audience and this next one, but nevertheless, you might find this interesting. It's looking at clinical coding and mortality metrics, and looking at how we record mortality. So if you are interested or got a vague interest in that, then join that webinar on the 17th of October. Sometimes it's good to hear from other people doing other things, and helps you to get a bit of perspective on all of our jobs. So thank you everybody for attending today. I hope you found it helpful. Let us know if you want us to follow up anything in particular, get in contact, and just remains to say thank you again to both Mikes. Thank you very much.
Thank you, folks.